Cheers, mate. So I work here 3 days a week at Arrow Park, and I'm genuinely very privileged to work here 1 or 2 days a week at Sandstone, which, if any of you don't know, Sandstone is a referral practice based in Heswell on the Wirral, owned by Fadi and Kate. And we have our own group of patients that we look after as a normal dental practice does, but we accept referrals from all over the place really for restorative, endo, implants or surgery. And it's a really, the team that Kate and Fadi have built is a credit to them. It's a pleasure to work there. A couple of days a month I also do sessions at the Ice Hospital in Manchester. I do solely implant work there, and I completed my master's through the ICE scheme, which is, I was after that asked to stay as an associate, which is a great place to work. And I also do the occasional list for Bridgewater Community Trust, but they're getting fewer and far between these days, or certainly at the moment anyway. A little disclaimer for this, there are several ways, as with everything in dentistry, to skin a cat, and some things I'll be saying are just how I have been taught or how I've found things work best in my hands. I will never be a person that says this is the way you should do it, or this is the only way that works, because there's loads of different ways, and you may have better techniques yourself that work for you or been taught differently, but it's always good to see someone else's point of view. I'll also be going through at a reasonable pace to get through this. So feel free to, either at the end, ask me questions, put questions in the chat at the bottom, or just stop me as we go, just unmute yourself and ask something if you want to ask it while the slide's on the screen. I'm going to do my best not to teach anyone to suck eggs, but I do have to cover some of the basics just for completeness. But in terms of aims and objectives, we're going to talk about assessing extractions and what guidelines are out there that can help you with making decisions on certain patient factors. Look at more alternative LA techniques rather than the bog standard ones that we use all the time, but things you can have in your back pocket if you need them. I'll talk about the instruments and techniques that I use for optimal extractions and how and when you might consider raising a flap, and then a bit of advice on surgical removal of teeth, and then suturing materials and techniques. I'll also look at, just briefly at the end, some of the complications that you might come across in ways that you can either avoid or manage them, and also look at, just very briefly, the use of CBCT, because I was emailed with a couple of questions about that. So in terms of assessment, I'll break it down into 3 categories: the patient factors, site or tooth factors, and then operator factors, so things related to you as the dental surgeon. For patient factors, clearly medical history is a massive part, but social history and past dental history are also essential to take into account, and past dental history with a particular focus on any extractions they might have had in the past. Dental anxiety plays a huge part in oral surgery and what you're able to do for patients. And age is really important, not being ageist, but it's just a physiological fact that as people get older, they have less elasticity in their bone, and their teeth are more sclerosed and more prone to fracture, and patients just don't heal quite as well post-operatively, so you've got to think about that. Medical history, I'm not going to do a comprehensive review of everything. I've just picked out some of the more important and focus points. Cardiovascularly, recent MIs, not that any of you will be rushing to treat people who've just had a heart attack, but you need to wait at least 3 months after heart attacks for any elective care at all, and ideally up to 6 months if you can, because before that their chance of a repeated episode is much increased. Hypertension, anything under 160 over 110 is actually genuinely really safe to treat in practice in primary care without any real extra precautions. Over that, the guidelines say actually there's not any documented major risk proven, but I would probably be referring them onwards because you're likely to see higher bleeding and they're at higher risk of a cardiac event. People prone to infection are uncontrolled diabetics in particular, and anyone with a blood glucose over 15, I would be cautious about treating, and certainly if they know their HbA1c, it's good to ask. Under 50 means they're reasonably well controlled. Over 50, I'd be a little bit more cautious. And you can always speak to the GP if you want to know that in more detail. Immunosuppressed patients we know all about. Chemo patients, patients on some drugs to suppress rheumatoid and that kind of thing. Bleeding wise, you've got your standard coagulopathies and clotting disorders. We all know about anticoagulants. Liver problems can knock out the clotting factors and the clotting cascade and cause bleeding issues, but also bear it in mind if someone's got a really knackered liver, how much local anaesthetic you're giving them, because quite a lot of local is metabolized in the liver. A good question to ask, or certainly to listen to if a patient reports it, is a history of bruising in general life, but certainly bleeding post-extraction, and that should be a bit of a red flag to you to pay attention to. The STSEP guidance I'm not going to go through, but it is superb. They've got a quick reference guide that's 3 or 4 pages long, and the QR code there will take you to the PDF later if you want it. But it's dead easy to find, and it's really helpful, and you can just print it out and keep it in your surgery for reference. Essentially, my advice is, in primary care, anyone on anticoagulants, read the guidance, follow it, keep the number of extractions per episode minimal, and pack and suture everyone who's on an anticoagulant, and we'll come on to that later. For bone stuff and healing, head and neck radiotherapy. Now, try and get a detailed history from the patient if they know it of where the radiotherapy was. And you can even, oncologists are so helpful in giving this kind of information, because if the area you're wanting to operate in wasn't in the field of radiotherapy, the risk is incredibly low of getting any complications. If the area was in the range of radiotherapy, you need to be referring it out into secondary care. Bisphosphonates we all know about, but ask about injections, because it's amazing how many patients forget to tell you about it on their medical history form. If they're receiving them once a year or twice a year, they might just forget to tell you, so ask. And rankle inhibitors and anti-angiogenics are kind of the more modern groups of drugs that have kind of mad suffixes and strange names that you might not come across before. So if there's anything in the medical history in terms of drugs that you don't recognize, ask the patient about it or look it up. Don't just skim over it, because you might miss something. Again, STSEP come in with great guidance, which is dead easy to understand and dead easy to follow. It essentially categorizes patients into low or high risk. It ultimately doesn't make much difference, because they say that you can take teeth out if you absolutely have to on either, and they don't advocate any special precautions really in terms of antibiotics or anything like that. Steroid, patients on steroids, people talk a lot less about these days. They tend to get a lot less excited about steroid crises in dental treatment. Anyone under the equivalent dose of 15 milligrams a day of prednisolone is totally safe to treat in practice without any alteration to the medication. If they're on over 15 and you're nervous about it, refer them in. But equally, if you're comfortable treating them, it's really easy to ask the patient to just double their dose on the day of treatment, and that is classed as their steroid cover, and it's absolutely fine to crack on. And allergies speak for themselves. If anyone wants a really comprehensive overview of medical issues and what impact it might have if you take teeth out, and what recommendations there are for you to do for the patients, then this book, this BDJ guide, has got a really good summary, about 2 or 3 pages long, and it's dead clear, so I'd highly recommend it. Social history, we sometimes underestimate, but alcohol will clearly affect possibly their compliance during the procedure, but certainly their compliance post-operatively. And again, if they've knackered the liver, we might have bleeding issues. Smoking massively increases post-op complications. Recreational drugs could be to your benefit if they're really chilled for the treatment, or it could have them bouncing off the walls or at risk of getting aggressive, so it's worth knowing about or suspecting. Their occupation really relates to making sure you give them adequate post-op advice and what they can expect to be doing, and whether they're going to need time off work, depending on what they do. And the home circumstances certainly applies to older patients who might need support, because taking teeth out and then difficult teeth can knock them for 6. Or patients who are carers for other people who might not be in a state to be doing that, and you just need to know what they've got going on at home so you can advise them properly. Their past dental history Attendance history and anxiety, I suppose, can sometimes go hand in hand, and it just gives you more of an idea of what this patient's going to be like post-op in terms of, can you rely on them to represent if they've got complications, and if you're going to be doing slightly risky surgery on them, because if they've not been through practice before, they very rarely come. It's a bit of a red herring, a red flag for you. Local issues, listen to the patient, or look in the notes and see if they've had problems in the past, because you might need to have a few things up your sleeve if you struggle. Have they ever fainted or been aggressive in the past? They'll tell you often that it's amazing. Patients will just say, oh, I can't go to that dentist anymore because the last time he came near me, I tried to punch him. And they just freely explain that to you. Difficult extractions is a big one. If they've got any history, or they tell you, oh, I always have trouble taking my teeth out, or I bleed for days afterwards, or oh, I get dry socket every time. These are likely to repeat for the same patient, so just flag it up in your own mind. Talking about tooth factors, I'll look at access to the tooth, what condition the crown's in, root morphology, and then what's the bone like around the tooth. In terms of access, it's obvious, but position, further back in the mouth you go, the more difficult it is to get to. But not just the position in the mouth, the position locally. Is the tooth tilted buccally or palatally or lingually, and is that going to affect your access? Are the teeth either side inclined and preventing you getting to what you need to? Are the teeth next door restored, in which case do you need to be careful of the restoration when you're going near it? Mouth opening, does the patient just have microstomia or a small mouth, and is it difficult to get to? If they've got trismus, what's causing it? If it's pain, might it release if you give local and sort the situation out? If it's due to a swelling, might you be able to incise it and come back another day, or give them antibiotics and revisit it? And gag reflex might make this a bit of a non-starter, but equally it's amazing what you can achieve with local anaesthetic and once they're numb, and it does suppress the gag. In terms of the tooth crown, mostly teeth we're taking out will be restored in some way, but what's left of the restoration, is it crowned or is it restored with a filling? And if there's caries, how deep does it go, both subgingivally and towards the bone, or in towards the tooth? The remaining walls of the tooth, what are they like? Are they relatively robust and strong? Will they stand up to sticking a pair of forceps on? And can you rely on them for application points, or are they likely to fracture? Because this all affects your plan going forward as to what you might think might happen. The root morphology, root number sounds obvious, but don't be caught out by extra roots, because they are there sometimes. I've had several lower molars that have had 3 roots, and you're wondering why it won't budge, and then you find out why. Root canal treatment, we all know, complicates extractions and makes a chance of fracture much higher. The condition of the root, what I mean by that is it solid, sound dentine that you can elevate against and rely on or grip hold of, or is it mushy and carious, or it has a bit of resorption, which makes life way more complex? And what's the general shape and divergence of the roots? Because clearly curved apices are very divergent, multi-rooted teeth are going to be more difficult to remove. The surrounding bone, how much of it is there? Has there been bone loss, which is probably the only area of dentistry where we want to see a bit of bone loss around the tooth because it makes life easier. And is the bone really dense and solid, in which case it's going to put up a fight, or have you got a bit of flexibility, or is it got a nice sort of sparse trabecular pattern, which means we might get away with more. And again, pathology is often our best friend, especially if the tooth's been sat in some chronic pathology for a while with associated bone loss. It makes life a bit easier. So just going to talk through a couple of cases to sort of talk through those factors as I'd look at them in the surgery, really. So focusing on this lower right 7, in terms of access, you can't see where the patient's opening, but let's assume it's normal. It's a lower 7, so access hopefully shouldn't be too bad. The adjacent teeth, the 6 has got a crown on it, so we need to be aware of that and warn the patient and be careful when we're extracting this. Looking at the crown of this tooth itself, it is crowned, as you can see, and the margins aren't the best and have potentially got secondary caries, so there's a chance, you know, when you stick a pair of forceps on that crown might be coming off, and just make sure you're prepared for it and that the patient is. The roots themselves are root filled. The front mesial root has got 2 canals, and to me looks like it may also have 2 apices, so whether that's 2 true roots or just a bit of an hourglass kind of shape, either way it might complicate trying to remove it. And there's a bit of a kink on that mesial root as well. So all in all, combined with the fact that the bone either side is fairly decent bone levels and quite dense possibly looking, that's not that straightforward an extraction. Not necessarily something that has to be referred, but it's not something that I would expect to be totally straightforward, and there's a reasonable chance of having to section this rather than just removing it with forceps. Totally different case now. Almost total loss of coronal tooth tissue on both the 6 and the 7, and the bit that's left on the 7 is not really worth speaking about because you can't rely on that. It's just going to fracture. The bone bit around it, there's been some crestal bone loss, and we've also got some furcational bone loss here, and possibly some apical bone loss up here due to pathology. So that will all work in our favour. The roots here have been root filled, but actually this root tissue that's stuck above the bone looks fairly solid, and hopefully you could get hold of that with some forceps or elevate against it and get those moving easily. And a similar story to the back there. The 7 here, really heavily restored, and everything beneath the restoration is knackered. There's kind of apple core caries through it, which means that there's going to be very little to stick forceps on, or very little that will remain intact. But you've also lost your application points, certainly mesially here, and potentially distally as well. And so that tooth, combined with the fact that it's got quite sort of curved and pincer-like roots, is almost certainly going to be a surgical removal, and probably one that I'd refer on, or that you should refer on, sorry. In terms of these teeth, this root, hang on, to go back on. The root at the front has got no coronal tissue left, and the caries is dished out quite subgingially. There's a chance that might come out with luxation and getting decent forceps on it, but there's also a reasonable chance that it's going to need a little bit of bone removal to elevate it. 6 has lost most of its coronal tissue, and the caries is almost through the furcation. There's very little bridge of tooth there holding those 2 roots together, and the root filled, and a little bit kind of pincer-like in terms of this bulbous furcational bone. That would almost certainly come out easy if you just go straight through that furcation from the start, and either with cow horns or with sectioning with a handpiece, which we'll talk about in a little bit, to take those out separately. And this actually is probably going to flick out dead easily because of the amount of bone loss that's around here, so we don't really need to worry about that one at all. This last one I've put in just to highlight what can be seen sometimes around lone standing posterior teeth, so posterior molars where they've lost teeth either side. Because they're under an increased load, you sometimes see in these areas here an increased bone density, and that can make things slightly more difficult for you in terms of getting these teeth moving. So if you've ever experienced that, lone standing molars tend to be quite difficult teeth to take out sometimes. So operator factors, it just depends on you and your background really. You know, what's your experience been? How much training have you had in oral surgery? Have you not done any since you left undergraduate? Or have you done DCT jobs where you've had loads? It just varies a lot with people. Confidence goes along with that really, but also your affinity for oral surgery, because some people will do anything they can to avoid taking teeth out. Other people really enjoy it and love to get stuck in and have a go. And your approach to risk will determine where your line is drawn as to what teeth you have to try and take out in practice. Equipment's also a limiting factor, particularly if you're not the principal of the practice and you don't buy the equipment. You're limited essentially by what your principal agrees to buy for you or what you've already got in practice. Consent can be verbal or written, and there's no right or wrong. Certainly, I'd say written is the gold standard if you can incorporate it into your practice. And if nothing else, the written consent means that you remember to tell the patient all of the risks, which otherwise verbally you sometimes can forget. But for me, consent's a conversation, and a proper conversation with the patient is your biggest defense or your biggest way of avoiding complaints or litigation. Really make sure the patient knows what's going on. I invite them over to the computer and I show them the radiograph and talk them through the procedure that's going to be involved in taking this tooth out. I'm not trying to make things worse for me by stressing them or scaring them, and I don't tell them horror stories, but it's important they understand, number one, the skill that's involved with what we do in taking these teeth out. It's not a dead straightforward thing, and it's not going to be a 2-minute procedure. But I also want them to be able to point out to them the risks that are associated with adjacent teeth and crowns and how they might get knocked, or the curve on the root that might snap, and all those little bits, because if they don't know all the complications beforehand and something happens, telling them afterwards by then is just an excuse. If you tell them before they've been informed of the risk and they said, well, yeah, you said that might happen, don't worry. Afterwards, it's just an excuse, even if you knew it might happen. And emphasize the post-op sequelae. So it's like anything in dentistry, in my opinion, undersell it and over-deliver. So tell them it's going to be awful. And if things aren't actually that bad, then they'll think you're a genius. The standard warnings that you all would give: pain, swelling, bruising, bleeding, infection, OAC for anything that looks near the sinus, and same goes for displacement of roots. Fractured tuberosity for all upper 8s, as well as OAC, but possibly for sort of 7s which haven't got an 8 behind them, and the tuberosity just looks a little bit iffy. Nerve damage, unless you're doing lower wisdom teeth, only really relates to any surgery and raising flaps around the mental nerve. The need for surgical removal, tell the patient if you're not planning on doing it from the start. And it's not a bad idea if it looks like a real difficult one, or like there's a high chance of it breaking and you're not comfortable to carry it on to completion. Just tell the patient from the start, look, if this breaks or whatever, we might need to refer you on, because it worries the patient less if that then ends up happening, that they've been prepared for it. Local anaesthetic. It's difficult in practice with the time pressures that you can be under, particularly in NHS practice the way it was, to take your time with local, but patients will massively appreciate it if you just spend that little bit longer on your delivery, because it's so much more comfortable for them. And for infiltrations, try and inject into a space or loose tissue plane rather than tight fixed tissue, because it's way more comfortable. So, for example, a lingual infiltration, rather than giving it up here, dropping it down to this free mucosa is so much more comfortable for the patient. Take care with the lingual nerve, obviously, and watch out for that, and also aspirate as you always would. Same on the palate, rather than giving it in the fixed keratinized tissue and lower down, just shifting the needle higher up to this area just makes things way more comfortable for the patient, because there's more space and more tissue planes for the liquid to dissipate. I avoid IDBs where I can, just because it's nicer for the patient, but there's also removes that risk of putting your needle anywhere directly near a nerve. I use Articaine for almost everything, and I know oral surgeons who use Articaine even for their wisdom teeth, but I've only just sort of recently learned that, so when I get back to work, I'm certainly going to be giving it a go. Buccal infiltration for a surgical removal of an 8, and they manage without any problems. So you certainly will be fine elsewhere in the mandible, as long as you give probably a whole cartridge buccally and give it a bit of time to work. Not long, 5, 6, 7 minutes, but you do need to give it a chance to kick in. Practice alternative techniques when you're at normal infiltrations either aren't possible because of swelling or just aren't working for whatever reason. And I use a lot of these a lot of the time. So intraleg is super short needle if you've got them, but you can do it with short needles as long as you're careful. Make sure the needle's right in the intraligamentary space before you start to inject. Intrapulpal I use if you've got a hot pulp, or if you've got just one of those teeth that just really won't go numb, and it's got to be with the patient's consent. But I will just drop straight into the pulp chamber with a handpiece and then inject in, and that works really very often, and it's very, very rare that I don't manage to do that. Obviously, sometimes patients are too much discomfort to allow it, but for a short, sharp discomfort dropping in, it often works really nicely. This is the Akinosi block, which I'm not going to go into today, but it's worth looking up as an alternative to an ID block, your standard ID block. It's a closed mouth technique, so it's great for patients who've got trismus, and it's just a good alternative to an ID block if the gag reflex, for example, is stopping you doing it, or you just can't get it done with your normal ID blocks. The infraorbital block to me is one of the most underused blocks in dentistry. So we all know the infraorbital nerve comes out beneath the eye and through the infraorbital foramen, and it drops down, giving us the anterior superior alveolar nerve, which supplies sensation to the canine to central incisor, and the teeth as well as the buccal gingiva. But if you're lucky, you might also from this block get the middle superior alveolar nerve, so you can in one injection get from 1 to 5 none in one go, which often I suppose you don't need to do, but if it's particularly useful if they've got a canine space abscess that you're trying to incise and drain, because if they've got a fully swollen sulcus full of pus, trying to give an infiltration in that area is virtually impossible. Or if you're trying to take a tooth out in that area and trying to give a buccal infiltration is too sore for them, doing an infraorbital block is a dream. And it might seem a bit out there for dental practice, but giving it extraorally through the skin is a really smart way of doing it, because you don't go anywhere near that swelling in the mouth. So your landmarks for giving it are the mid-pupillary line and the top of the alar. And where those two lines sort of meet, you just feel with your finger. Go straight through the skin like an ID block to bone, using a long needle like you use for an ID. Touch bone, retract, and just give a cartridge really slowly, or half, 2/3 of a cartridge, whatever you feel confident. But that is a real nice technique for patients who've got canine space swelling that you need to operate on. So stop me as we go if anyone wants to ask anything, but we can come back to questions at the end otherwise. Extraction techniques. Preoperatively, get the patient in the right position. So many times we forget to move the patient in the chair that's comfortable for us, and we just leave them where they are. Chlorhex mouthwash is slightly controversial because people are really scared these days with the risk of anaphylaxis, but there is evidence that suggests that you get less dry socket by using it preoperatively, and I just do a 30-second, 1-minute rinse. Pre-op analgesia, if you can remember, it makes the patient feel a bit cared about, and it definitely does improve their post-op pain. 400 milligrams ibuprofen, unless it's contraindicated, is great. Get your x-rays up, make sure your screensaver is not going to kick in halfway through the procedure so you can't see it. I would get all instruments and materials out that you could possibly need. So plan A, plan B, plan C, plan D. You don't need to open them all, but have them in the surgery, because it's so much more slick if you've got it all there and you need it. If you break a tooth and then say to the nurse, oh, can you go and get me such and such, and they have to run out the room and deglove, the patient's panicking because the tooth's just broken and now the nurse has run out for a new instrument. If it's right there to hand, it's so much better for them and for you. Make sure you've got adequate anaesthesia before you start, because if you start treating a patient who's not numb and you cause them pain, you're already on the back foot. And a WHO checklist, we use these in the hospital all the time, and they are starting to become more commonplace in practice as well. Simon Wright's going to give us a talk in a few weeks on human factors, and this is certainly one thing that he advocates in just trying to reduce wrong site surgery and trying to reduce taking the wrong teeth out. In particular, ortho extractions is the classic, isn't it? But it can happen to any tooth. And when you're approaching the tooth to remove it, have the end in mind. So what's going to replace it? If there's nothing going to replace it, and the patient's adamant about that, then ultimately you don't have to be too concerned with how you take it out. Although every tooth extraction should be atraumatic, in my opinion, you've got a little bit more leeway. At the moment, sadly, nothing is going to replace any of the teeth that we're going to take out, hopefully, when we get up and running, I imagine. But think on the patient's behalf, think about the future. Are they going to want an implant there one day? Are they going to want a bridge over it? In which case, do we need to try and preserve the bone from now for the future? Because ridge preservation is a non-aerosol generating procedure, it's really quite straightforward to do, and it's something that, in my opinion, anybody can do if they've been shown how to. It's not complicated. And we'd be doing our patients a huge favour if it's the right situation in ridge preserving for them during this COVID period, so that the bone is hopefully still there for them whenever we can get back to doing normal treatment. It's not the end of the world if you don't ridge preserve, don't get me wrong. It doesn't mean they can't then have an implant in the future, or they can't have a bridge over the top, but the amount of work you'll have to do to get a better result at the end will be reduced. There's no doubt about that. So in terms of instruments and kit, essential, this is my opinion of what's an essential list. Luxators, I think, are elevators, forceps, scalpels, or even if you're not that keen on raising a flap, you should have them available. A suture kit's dead easy to put together. It's literally holders, scissors, and tooth forceps, and have them in a packet just for when you need it. And you've got to have some kind of hemostatic material in your practice, just in case you get a bleeder. Hemocollagen sponges are dead cheap and dead easy to use, and Surgicell's way more expensive. It's lovely stuff and it does a great job, but it's so expensive. Just a little note, if you are ordering it or if your practice are ordering it, make sure they check the size of sheet that they're ordering, because some of them are huge and they're ridiculously expensive and you get so much waste. So especially if you're the principal, don't get a shock. And Willowcell's just an alternative brand. It's a bit cheaper. Excavators or curettes. These are Lucas curettes, and I definitely would use those for just degranulating the base of sockets once you've got the teeth out. Things like periotomes are optional. They're nice to have if you need them, but by no means essential. Retractors are only really necessary if you're going to be raising flaps, and same. Surgical aspirators are easy regardless, to be honest, of whether you're raising flaps or not. They're just dead handy for doing oral surgery of any kind. Drill you only need if you're going to section teeth or drill bone. Good light and loops, I was hesitating to put them in the essential. I use loops with a headlight for all of my oral surgery, even just taking teeth out. And some people might take the mick out of me for that, but I think it makes me a better surgeon, particularly for sectioning teeth, raising flaps, and drilling bone. I see so much more, and the light is just makes life so much easier. Luxators have to be sharp and are not elevators, so don't elevate teeth out of their sockets with them, because you will just blunt them or you might even break them. They're used for stripping soft tissue off the side of the tooth and for socket expansion and mobilizing roots but not elevating them, and obviously incising periodontal ligament around the tooth. So most of the time they're used along the long axis of the tooth, and they're kind of inserted down the side into the periodontal membrane space, and that's the key, is making sure that that's where you're putting it. And then a kind of rotational movement, almost wiggling it with apical pressure. And the idea is you hopefully get the root moving and open up a space, and then push the instrument further apically and get it moving again, and go further apically and move again. And by doing that, you'll get real good mobility on the tooth, coming at it from different angles and different sides. They're sharp, and they don't let students use them in some places because you can do a lot of damage with them if you slip, particularly when you're putting a lot of apical pressure on. So this kind of hold is essential, really, with this finger pointing up the shaft as almost like a stopper or as a finger rest if you're going to slip. And that's a top tip for using luxators safely. Periotomes have a similar action, but you don't get anywhere near as much purchase on the root. They're mainly for incising periodontal ligament, but they're part of the armamentarium of doing an atraumatic technique. You put them down the periodontal membrane space and either use an up and down sawing action or a bit of a side to side rocking action. Elevators everyone's familiar with, but I have to say, from my experience of having DCTs coming through our system for the last few years and training under me, they're probably the most underused or misused instruments that we have. The amount of times I've seen people feel like they're almost obliged to pick a Coupland's up and insert it between two teeth and wiggle it before they then go on to use a forceps, even though it's made absolutely no difference to the extraction. It amazes me. You don't have to pick a Coupland's up. You've got my permission. It's okay just to go straight for forceps, particularly in reasonably sound rooted, sound teeth or sound roots. You can get a good grip of that's conical, and just a rotation will remove it. You don't need to elevate if you don't have to. By all means, strip the soft tissue away from it to preserve the soft tissue, but it doesn't necessarily need elevating. Cryers are really underused, and anyone who's worked with me probably knows I use cryers relatively often. And Warwick James in a similar way. Particularly straight Warwick James is a really handy little instrument when contact points are really tight between teeth for getting in and just opening it up to start with. And it's a great instrument. And you've got to think outside the box sometimes. I remember as a student, I wanted a box for every instrument. That's what this does, and this is the situation where I use that. But they can be used anywhere in the mouth in any way that you can make them work. And there's all kinds of weird and wonderful ways that you can use them and find that they'll help you. So just an example of cryers. And one of their classic uses is for removing a second root when you've already removed the first root in a lower molar, for example. And you can just take it through the furcational bone and elevate it through. A lot of people get worried about doing this, and you can't do it if the septal bone's too thick. But if you've got a sort of, a millimetre or so, a couple of millimetres of furcational bone, there's absolutely no detriment to the patient if you just go through it and use that as then your application point to elevate a root in that way. And it's a really, really handy trick of getting otherwise difficult roots out. It'll have no major detrimental effect to the patient long term, trust me. Another handy little trick with cryers is creating your own application point in a tooth using handpiece. This has to be done actually with a bit of care, because if you drill too near to the top of the tooth and you elevate, it will just fracture a chunk of dentine away and probably leave you in a worse position. Equally, you've got to drill your angle so that you engage when you're trying to elevate and don't just slip out with the cryers. And obviously the tooth shape's got to be favourable to this. If it's got a hook on the bottom, it's not going to elevate like this, whatever you do. In terms of forceps themselves, especially now that practices are dead, if you get a chance, go in and have a look through the practice stock generally. I know it's a sad thing to do, but you'd be amazed at what you've got, and you'd be amazed at the difference in the beak shape and size. Not all upper molars or lower molars are the same. So pay attention to what you've got, because you might need to try a couple to get one that fits the tooth properly. So just be aware of what you've got. Be open-minded how you're using them. A bit like the elevators, you don't have to use every tool in the way it was initially described. So a lower molar or a lower premolar forceps can actually be really handy on an upper tooth when you've got limited opening, because that 90-degree angle is really handy. And in the same way, for a mesially tilted posterior tooth in the lower jaw, for example, like a mesially inclined lower 8, an upper set of premolars is actually a really nice angle for diving to the back and getting a hold of that crown to bring it through. It's really important that the beaks of your forceps are well adapted to the tooth and the root surface, because you have a much higher chance of breaking the tooth if it's not, and you might have to go through a couple of sets to find one that fits, but it's worth it. Root forceps, ideally, if you can get hold of them, nice long, quite narrow tipped ones, so that you can get down to those broken roots that are almost sharp tipped. And if you can, practice ambidexterity, because if you can take teeth out with both hands, it makes your life in surgery so much easier rather than having to change sides or stand in funny positions. This is just a diagram to demonstrate what I mean by the tooth, the forceps being well adapted. So contact with the crown and contact with the roots. In a situation like this in the middle, when you start to apply forces, you're likely just to fracture the crown off, and you can see how that can happen. Bit of a shout out for cow horns. I'm a massive fan, and I think they've got a massive role to play at the moment in taking teeth out, particularly lower molars, when we're not going to be able to section them with handpieces like we normally would. You can divide an awful lot of things with cow horns in the same way that you would. It's a bit less controlled and it's a bit less pleasant for the patient because there's a hell of a crack when you do it. But it can make life, it can get you out of some sticky situations. So definitely consider using them. You need a clear furcation on the tooth to engage with. You will potentially be able to deliver the entire tooth in one piece with them because they're great. And sometimes you actually get the tooth jumping out of the socket if you've got favourable root morphology and quite a solid crown. Apply them, give it a real good squeeze. Warn the patient there might be a loud noise or a crack, and then crack on. Just a little tip, if the roots do separate while you've got a squeeze on them, don't just pat yourself on the back and let go and then go to your next instrument. Keep a hold of your grip and try and deliver the tooth still, even though they've separated, because sometimes it will still come out all in not in one piece, but all at the same time, because that fracture has allowed them to move where they want. And you'll at least often just get one of the roots out, and then it'll leave you with just one to go back in and get. So do try and, even though they've separated, do try and deliver both roots at the same time if you can. I was certainly taught, and I think most people were, push apical and buccal, but it kind of drives me mad for a couple of reasons. Don't get me wrong, going apical and buccal will probably work quite a lot of the time, but you've got a massive risk of decoronating the tooth if that's all you do. And you've also got an almost certain risk of fracturing the buccal plate, which if they're not having anything going in place afterwards is not the end of the world for the patient, but is a nightmare if you're ever thinking of an implant, or even just cosmetically, it can look awful after it's healed. A couple of cross sections of CTs just to demonstrate why I don't like that approach. And the one on the left over here, you would almost certainly get away with pushing apically and buccally, because you've got a real nice conical domed root morphology and quite a thin, fairly sort of flexible looking piece of buccal bone. So that will almost certainly deliver buccally with a bit of apical pressure, no problem. But another, if you look at this molar here in the middle, look at the width of that buccal plate. There is almost no chance that's just going to flex and let you pull this tooth out if you think about how much is in your way. So you're either going to end up with a massive buccal fracture, or you're going to take the crown off, or it just won't budge, and you're going to need to think about plan B. And in the posterior mandible, again, the cortices are normally really thick, and you've often got a kind of buccal shelf, which is mega thick, and there's no chance again that just going buccal on that tooth is going to deliver it. So what do I sort of advise, or what do I do? Apical pressure, yes, definitely, always. Buccal, yeah, absolutely, some of the time. And certainly buccal movements are part of delivering the tooth, but just not solely buccally. The conical roots, as I've described already, often getting a good grip of them as low down on the root as you can get, and simple, firm, solid rotations forwards and backwards will just tear the periodontal ligament, and is enough to then deliver the tooth dead easily and really atraumatically. And you don't need to go buccal at all, just conical root with no curves or hooks on the apices, just rotation. Multi-rooted teeth, people talk about figure of eight and stirring a pot, and I've kind of coined the phrase multi-directional socket expansion, which sounds a bit la-di-da, but makes sense if you think about it. It's essentially getting a hold of the multi-rooted tooth and trying to move it in 3 dimensions to expand the socket in every way, and to then hopefully allow you to deliver the tooth once you've made a bit more room for it. Your movements with forceps should be slow, controlled, deliberate, and sustained. I've had people come and work with me in hospital who are literally jiggling it around like they're almost having a seizure and trying to get a tooth out, and you're just going to break teeth, and the patient's going to wonder what the hell's going on. You need to be deliberate and slow with your movements and sustain pressure in each direction to get that expansion of the bone. It doesn't mean it's going to take forever, it just means that your dilation needs to be careful. And my tolerance for dividing roots normally, when we're allowed to, is quite low. So if I've had a go at a molar and that's not been moving after a minute or two, or I'm not feeling that there's any dilation of the socket, I'm confident it's going to help get the tooth out, then I'll just divide the roots, because it saves me and the patient a lot of time and pain. Does someone want to ask something? No, I think somebody's unmuted. The diagram on the left over here just gives you a picture of what we're on about with dilating the socket. So normal tooth in a socket over here, once you've wiggled it around and dilated the socket, you hopefully create a lot more space to be able to elevate it from. The diagram on the right is a bit of a bird's eye view of a lower molar forcep on the lower molar, and it's just that figure of 8, trying to give you that sort of idea of you want to be moving it in every direction. It doesn't have to be a pure figure of 8, it can be anything you like, but you'll often find that once you get the tooth moving, there's a certain way it wants to go, and focus then on that way where it starts to give more, focus more on pushing it in that direction, and you just notice that it starts to ease up. So sectioning molars, a few tips on that when we're allowed to do it again, whenever that will be. It can definitely be done without a flap. In fact, one of the indications for sectioning molars is to stop you having to raise a full-on flap and do bone removal. Trying to section the roots before it gets to the point of having to be a surgical. To do it though, you need to assess the tooth favorability. So looking at the root morphology and number, is there a clear furcation, and where is the furcation? Is it quite low down in terms of apically, or is it quite coronally, which is favorable? And what's the crown root condition like? Because are you going to need to do a surgical anyway if you section these roots and there's nothing left to elevate against? So just a couple of examples. This is a tooth that you could have a go at with cow horns, or you could have a go at with forceps, but it's so heavily restored coronally that you're likely to just snap the top off, I would imagine. This is probably one that I would electively section from the start if I could, and just divide straight through the middle, and then treat it as two separate teeth, because you've actually got quite a lot of reasonable tooth tissue here. And if it's sectioned and you can keep that lot intact, or at least elevate on this decent bit of root here, you stand a chance of getting these otherwise fairly straight roots out separately in one piece through sectioning. This is another tooth which is relatively close to the antrum. It's crowned, which complicates factors, so you'd likely have to remove the crown before you section it. But there's definitely a clarification, and with that little kink there, sectioning this might be beneficial in terms of reducing your chance of an OAC, and also not having any issues with that kink. Once these other straight roots are out of the way, you can sort of curve that round separately. Another same position, upper right, sixth tooth, but this one is totally different because it's really heavily restored, and you will have lost your landmarks in terms of sectioning, and there's no obvious fixation to see that you're going to aim for. And so sectioning this is going to be incredibly difficult. I don't know if you'd need to anyway, to be fair. It's quite a favourable route for delivering normally, so you probably wouldn't need to, but anything that looks like that with close roots, no obvious fixation, is probably a non-starter. You need to be able to access the tooth that you're trying to section, because you've got to think about the height of your burr and your handpiece, whichever type of handpiece you're going to use, which we're about to talk about now. So absolutely barn door safe, and gold standard is a surgical handpiece, obviously. But a speed increasing electric handpiece, like these red banded NSK ones, are totally safe to use, and actually really nice to use for sectioning teeth because they cut through teeth like butter. And they're great for all restorative stuff as well. They really do cut teeth nicely if anyone's thinking of upgrading. And you can happily section teeth with these, no problem at all. It's also okay to use reverse exhaust high speed with compressed, they run like a normal high speed on compressed air. And because they, as the diagram shows, exhaust their air backwards, so there's no risk of emphysema. But sadly, with standard high speeds in like most normal practices use, I can't advocate using them. People do, and people have for their whole career and have had no issues whatsoever. And the risk of emphysema is, I agree, totally minute, but it's still there. And if it ever happened, it would kind of be indefensible. It's a personal choice. If you're within tooth structure and drilling, there is absolutely no risk of emphysema. But as soon as you come sideways out of the root and go into the soft tissues or near the soft tissues, the risk begins. And also as you drop down through the tooth surface into the fixational bone, there's technically then a risk of emphysema as well. And there are case reports out there if you look for them. So the key is obviously knowing this tooth's individual root morphology and sectioning it accordingly. So look for anatomical landmarks and work your way through to separate the roots and bring them out. My tips would be commit. If you're going to do it, go for it and go all the way through the tooth. Don't bottle it, because if you leave bits of tooth intact, you will just fracture and you'll leave yourself in a way worse position. Take care at the extremities of the cut, in particular of the lingual mandible. You know, when you're pushing quite hard to get through the tooth and you reach the end, you can fly through. Just be careful and take care, because especially on the lingual mandible, the lingual nerve does run quite close to the lingual plate in a surprising number of cases, and you don't want to be sticking your drill straight through the lingual plate into the nerve. Good tips are that as you do it more, you'll start to feel the tactility of when you drop into the fixation. It's a bit like when you drop into a pulp chamber. You've got pushing against tooth, and all of a sudden you get that drop, and it's exactly the same when you drop into bone through the fixation. It's always deeper than you think. If you think about how deep you go for a pulp chamber and then look at a radiograph, the fixation's, you know, that again, but it is quite a long way down, and you need quite a long burr to get through to it. And if you're looking at the cut as you're going to know if you've dropped down, a good tip is that it will be bleeding at the base. If you can see white tissue that's not bleeding, it's tooth. If it's bleeding, you're likely in bone. Keep your burr parallel with the long axis of the tooth, and make sure that you're using reference points and checking them up as you go to make sure that you know where the tip of that burr is and that you've not gone off on a wonk in any way. And keep your cuts fairly narrow, so the channels that you're cutting don't make them enormous, because if don't make them too narrow, you still need to get an elevator in, but you want it just the width of an elevator so that you can get good purchase point per elevator. We'd said earlier this is one of the reasons that you can avoid raising a flap, but equally it doesn't mean that if you need to raise a flap that you shouldn't, because sometimes, particularly if you're not clear where the furcation is, raising a little flap, a dead easy small flap, will allow you to see so much more and really allow you to see that shape of the root as it sort of creeps in towards the furcation, and it might guide you. Once you think you're through, check that your roots are separated with something like a Coupland's or a straight Correct James, and insert it as deeply as you can into the cut, because if you just give it a tweak quite high up coronally, you're likely just to fracture chunks off. Then once they are separated, luxate and elevate them gently with root forceps to then deliver them. So the kind of tooth that I wouldn't section is one like this, because I don't think it would get you anywhere. It's going to need to be a surgical removal anyway, and there's no clear furcation to aim for. They might even be fused roots. But ones that may well benefit from it are things like this. So this one on the right, it's got a slight curve on this root, but I just really don't like the look of that root. It's so long and thin, and it's got this kind of little dog leg kind of sticking its leg out kink on the front there. And I think trying to deliver that at the same time as this one means that the chance of this fracturing across here have got to be really high. If I section that from the start, I can take this fairly nice straight distal root out of the way and then bring that into all this space that you've created. This lower left 8 is a tooth that I have taken out. And if you can notice, yeah, it crosses the ID nerve. We did a scan and it was safe, but nonetheless, it was a pig to remove because these were actually fused at the apex. So even separating them didn't do me many favors because they were still fused down the leg. So it's the kind of thing to look out for. Post-extraction, you'll all know what you're doing. Check your apex is intact. Debride the socket if there's apical pathology. I think this is one thing that people don't do enough of. If you've got a good chunk of granulation tissue at the base there, it's really satisfying. Get stuck in, get rid of it, use a curette and clean it out for the patient, because you'll make a massive difference to their healing, particularly if they're potentially wanting bone and implants in the future. It will fill in with bone way more easily if the body doesn't have to do the job of getting rid of that yucky tissue itself. Clean it out and give it a wash out. However, only irrigate if you've caused debris or if you've debrided. If you've just taken a tooth out that was relatively clean, there's nothing in the base of the socket for you to see, don't bother irrigating with saline. You're just going to disturb the clotting. Just help them to achieve a stable fibrin clot, which is all you're aiming for. If you've taken out a multi-rooted tooth, just have a little look at the septal bone that's left behind and make sure that it's not fractured and splintered. Same goes for the buccal plate, because leaving bone in place which has got poor viability and is likely to either sequestrate or just necrose is probably worse for the patient's healing in the long run. So just take it out at the time, and it's not going to be of any use to them. It'll probably die anyway. Packing, I would only pack if you've got concerns over bleeding, and when you do pack, don't overpack it. It's a foreign body at the end of the day, and the body's got to turn it over to do its final healing, so it's going to delay healing as much as it's going to help with clotting. Suturing, yeah, I mean, again, only if you need to, and just for a time's sake. It's not going to do any harm, but there's no need to if you don't have to. If in doubt, refer, and seriously, especially during this period, if you're not comfortable and you don't want to get yourself into a situation where you feel you or the patient's going to be worse off after, then just pass them on. We'll take it through the normal route into hospital. As soon as we are able, we're going to be open back up again in Sandstone, and I absolutely accept referrals for any teeth or helping you out with any patients that you don't feel comfortable treating for medical reasons or anything else. If it's inappropriate, give me a ring and I'll let you know if it's suitable for secondary care or primary care. We can always have a chat about it on the phone first if you want to. But yeah, there's going to be a lot of patients out there that are going to need our help coming up. And I do worry about how it's going to be in the hospital. It's going to be like facing a tidal wave, I think, but we'll be ready for it. So raising a flap, only do it if it's necessary, because if you can do any of the stuff we talked about already, then it's better for the patient. However, don't make a mountain out of a molehill, because raising a flap is really not difficult and it's not scary. And I remember dental school when people talked about picking up a blade and oh, it's gone to MOS, you know, and it's like red lights went flashing and everyone ran to watch. And it's really not a big deal to raise a flap. It takes seconds when you're good at it. It doesn't necessarily mean you've got to remove bone either. You can raise a flap just to see a bit more. It does make life so much easier because you've got increased visibility, you can see more. You get less bleeding, believe it or not, because you've moved all of that damaged soft tissue out of the way, and so it's a clean flap. You don't get much bleeding from the bone at all. And it just gives you much more accurate placement of your instruments, like your luxator or elevators or even forceps. You can see what you're putting it on, and you're much higher chance of delivering the tooth safely. Flap design, you'll all know, envelope one-sided, two-sided, or three-sided. If you're going to do relief, you need to think about where you're going to put it. We'll talk about that in a minute for your relieving incision. And it's always full thickness in these kind of scenarios. So your blade goes right the way down to bone so that you raise the periosteum intact and leave clean bone on the inside. Considerations when you're planning your flap is access. How much do I need to see? Don't raise more of a flap than to give you vision to what you want to see. The blood supply to the flap is essential. As long as your flap is wider at its base than its top, you'll be fine. Vital structures, the only thing is the mental nerve and staying away from that. Aesthetics, don't do relieving incisions if you can avoid it at all in the aesthetic zone. So maxilla 3 to 3. It's just most of the time not necessary and the patient won't thank you for it. Also try and avoid the canine eminence. But another thing that sometimes you don't think about is raising flaps around crowns, so on adjacent teeth, particularly if it's near the anterior, because you will always get a little bit of recession and patients will really not thank you or complain if they've then post-operatively got a visible crown margin. So they need to be warned about it if you're worried about it. Tell them from the start before you do anything. And any flap you raise, you've got to close. So just bear that in mind in terms of planning and access for that. So just talking through a case, the likelihood is you might be able to get, I'd like to hope I'd get this out without raising a flap, but for argument's sake, let's say that you needed to raise a flap. So if we put the gingiva in, and that's kind of what you can see above it. So if we did need to raise a flap, we would either just want to raise it to see our instrument application to make sure we can put our forceps on sound root tissue that we can find, or we might need to remove just a little bit of bone to give us a bit better of an application point. So we're not talking about huge access here. So a little envelope flap from here to here is probably going to be enough. In terms of on your x-ray, in your own mind's eye, trying to think about what size flap will give you what access. If you draw a line from the end of your flap to the other end, and then sort of make that curved almost to give so you get a bit of account for the elasticity of tissues as you retract, then that dotted line is basically everything below it is what you'll be able to see by raising that size of flap. Now, if that broke or decided it wasn't enough and I wanted a bigger flap, because it's an envelope, I can just stick in a relieving incision. This is my new line and my new curve, and all of a sudden I've got way more vision and way more access to more bone and root surface to carry on. And you can do that when you're doing it. There's no reason why you can't turn an envelope into a two-sided if you need to as you're going. Little thing here, this is a 4, so the tooth to the left is a 3. That's why my relieving incision is distally, because I wouldn't want to put a relieving incision either over the canine eminence or between the 2 and the 3, because it's just not necessary. This tooth's a different story. This is a resorption case and it was a nightmare to take out, and clearly for this I'm going to need to do a full-on surgical removal and remove bone. So that's the area I need to get to. A much bigger two-sided, not that big, but a bigger two-sided flap nonetheless from the start. And by the time I've raised it back, that will give me plenty of access. Now, if you notice, I haven't even had to go all the way around the 6 or all the way around the 4. And you don't need to necessarily doing that will give you much more access, and it's easy enough to do, but you don't have to be raising huge flaps to get good access. But equally, don't limit yourself, because the saying goes in MaxFax, a big flap feels the same as a small flap. So be conservative, but don't restrict yourself. So tips for raising a flap, in my opinion, a 15 blade is the only blade you need. 12 blades, which are the sort of the hook-shaped ones, like a scythe, are great for getting in little nooks and crannies sometimes if you need it, but just to keep stock down, a 15 is great. and disposable ones if you want to. Cut with confidence and trust yourself, but having support from your other hand is always a really good idea, particularly as you're doing relieving incisions, because it's so easy with just one hand to just slip on bone, especially if you've got kind of undulating buccal prominences. So support from the other hand is a really good tip when you're doing relieving incisions, to make sure it's controlled. You need adequate pressure down to bone, and make sure you do cut down to bone, and try and do it in a smooth movement rather than a kind of jumping from one place to the other, particularly around gingival margins. But at the same time as you want adequate pressure, you don't have to push as hard as you possibly can, because it's going to make it difficult to drag the blade along and make you cut, and it's also just going to blunt the blade, so you're going to end up with a worse outcome. Cut with the belly of the blade, so the kind of curve here, not with the tip. You can do bits with the tip, but the majority of cutting needs to be with the belly. And cut once, cut again, and then at the papillae, cut again. Honestly, I go through my incisions probably 2 or 3 times in both directions before I try and raise it, because that makes your life way easier. And most people struggle with raising flaps because they haven't made a good enough cut all the way through. So just make sure you're through. As long as you go through your same incision line, you're going to make no difference to the patient. Raise the flap once you've made your cut, in my opinion, with a curved but fairly sharp-ended instrument, so like a Mitchell's trimmer or an Ash or Ward's elevator or an Obfugieser, a bit like the ones on the right-hand side. If you've got a relieving incision, start in that with the tip of the instrument on the bone, and keep that curve, the tip on the bone, and then sweep backwards. Because as you keep the tip on the bone and push, the curved back of the instrument just sweeps away that periosteum in one nice sheet, and you get a really lovely clean flap, in theory. And it should happen, to be fair, if you've made a good incision. If you hit any snags or difficult areas, rather than ramming your elevator around it, just pick your blade up, hold the flap you raised so far under tension with your elevator, and just release the snags with your 15 blade again, and you should find it'll just fall away. Retraction, I'm sure you all know about, but instruments, personal preference. Rake retractors are a little bit old school, and I would definitely preach caution with them, because they can do quite a bit of damage with those kind of hooked fingers and holding them when you're not paying attention. Minnesota is what I use all the time for everything, and it's great, and especially if you're using a drill, that little trough in it is a good way of protecting tissues from the drill by putting it in between the two. Use your nurse to retract if you need both your hands for what you're doing, and just make sure you give them good instruction and position them and tell them where to hold the retractor and keep it. And take care with your flap, because you can cause quite a lot of bruising. If you have raised a minimal flap and it's putting a lot of pressure on, consider a relieving incision before you tear it, because tears can be unsightly and a bit of a nightmare to manage when you're closing. So definitely always make it bigger yourself electively before you tear it. And nerve damage is, again, mental nerve. Just be careful in anything around that area. If you're going to do bone removal, it's got to be a surgical handpiece. I prefer Fisher burrs for taking teeth out and bone removal, but there's nothing wrong with round burrs, and a lot of people use round burrs. I just prefer the narrow channel that Fisher creates. Your aim of bone removal is to increase the visibility of the root, and also create yourself an application point to get it moving, and maybe even create a little bit of space around, and if it's quite compacted in, to get the root of the tooth out. My tips would be put your foot flat down, maximum speed, foot down on the pedal, because feathering it in and out is just purely a lack of confidence. And I see it all the time in people who are a little bit unsure, and it's totally understandable. But all it does is reduce your cutting efficiency and create more vibration for the patient. And cut with confidence, but your confidence will be affected by visibility, loops, light, good suction. Use a surgical suction tip if you've got them. Kind of essential, in my opinion, if you're going to be doing proper surgical removals. And all of the above will improve your accuracy with your cuts. Doing this under magnification means your accuracy of cut is so much cleaner. And with experience comes tactility. You can tell the difference between bone and tooth when you're cutting, and that will guide you when you're doing it. So just an example of your standard surgical removal of a decoronated lower molar. You raise your flap and put your Fisher burr down the side to create your buccal trough. Section the roots, stick in something like a coupons, and then hopefully it's as easy as that, it just elevates out. And that's the kind of idea. So you can see how you've gone from something that looks quite difficult to something that actually is really quite easy. And there's nothing scary about doing that. The only thing you have to be careful with is making sure that you're cutting where you think you are. Because if your drill wanders into the tooth, which is really easy to do if you're not very experienced, and you create a trough more like this, it doesn't look much difference. But actually when you try and elevate it, it won't go up because it's in the way, it's catching on the instrument that you're trying to lift it past because you've created that little edge. It's not the end of the world. You can rescue it by doing something like this, just deep humidification and flicking it out that way. But in doing that, you might fracture it further. And always remember the little tip of sticking a file in if you've got a tiny little piece of root at the bottom of a socket that you can't get out. It does genuinely work a treat sometimes. So we're getting to the end, guys, and thank you for sticking with me. But talking about closing up now, or suturing sockets if you've had any bleeding issues. In terms of types of suture, resorbable and non-resorbable, in most cases in practice, I would expect that we use resorbable. I don't see any reason why you shouldn't, unless it's for cosmetic stuff. And you can get braided and monofilament, but most resorbable stuff like Vicryl is braided. People don't tend to pay much attention to it, but needles do come in all sizes and shapes. You won't really be using straights unless you're repairing your trousers. Most needles that we use in the mouth tend to be a 3/8 circle or a half circle. Cutting versus reverse versus round is one of the biggest things that people don't know. And I think if there's one thing you take away from this, almost, it's this tip. Because especially if you're inexperienced with suturing, it can be a nightmare pulling your suture through the tissues when you're trying to tie, or you're trying to feed it through, and you just end up making a mess of the gums. A lot of that is often down to the needle that you're cutting with, and it's the cross section of it. So what you always want to be using is a reverse cutting needle. And what that means is that the profile is a triangle, the cross section, and the pointy bit, the cutting part of that needle is on the back of the curve. So as you pass it through your tissues, it's not cutting upwards, whereas a conventional cutting needle cuts on the inside of the curve, and that makes you got a higher chance of pulling through, which I'll show you in a moment. You can get round bodied needles, which are much lower chance of pulling through, but they can be quite a pain to get through keratinized tissue at times. They don't go through as nicely as reverse cutting. So this is just to show that this is what happens with a forward cutting needle. As you pass it through the tissue, it creates this little nick and incision in the top. And if you can imagine that propagating as you put your needle through, it's really easy to tear through the flap. And if you've ever found you've struggled with that a lot, just check what needle you're using, because I bet it's this. Even if you get the needle through, when you go to tie your knot, especially if you tie it too tight, your suture will cheese wire through the soft tissues through that nick that you've created. On a reverse cutting, you can still do all of that, but it's much more difficult. And this is my workhorse, is a 4/0 Vicryl reverse cutting, so dissolvable reverse cutting with a 3/8 needle, and I use that in almost every situation, apart from I use a 3/0 if I need a bit more strength. Sutures, I'm sure you all know, single interrupted is the standard. If you've got a socket that you want to squeeze a little bit though, you can consider a horizontal mattress, or one that I use that's quite a neat little modification is what I call a figure of 8. And that's great if you've put a pack in that you want to hold in place, or if you've got a sponge in of some kind. It's just a little crossover technique with the knot to the side that holds things in place and gives you that kind of squeezing together. A little thing with this one is, you sometimes find that when you've done your first throws and then you go to do your second one to lock it, because of the tension it's under with that figure of 8, it tends to loosen. So when you do your first throws, rather than going around twice one way before once the other, go around 3 times that first time. So 1, 2, 3, put it down, and then 1 the other, because that extra throw gives it more friction on the thread, and it means that it will hold better as you're waiting to do your second throw. Vertical mattress is not particularly relevant for anything that we're talking about, but it's there. Top tips for suturing. Put the needle in the holders at the most favourable angle that will help you in the position you're trying to suture, and that changes as to where you're stood and where you're trying to suture in the mouth. So many people I see load it at 90 degrees and then try and put their hand in a mad position or try and turn themselves upside down to try and get the needle to rotate through. It doesn't need to be at 90 degrees. It can be at any position you want, as long as it's held firmly. It can be straight on with it if you want, and in fact I do that sometimes for buccal sulcus suturing. And it just make it easy for you to rotate your hand with the instrument and adjust the needle angle accordingly. Make a conscious decision about what you're going to do with the needle, and don't just chuck it down and forget about it while you're tying, because the amount of times I see needles dangling at the bottom and tickling patients' ears and all this kind of stuff. Just either, if you can't gather, then leave it safe and just make sure you know where it is and make sure your nurse knows. This is a great tip. Once you've made your first throws and you're about to do your second one to lock the suture, don't put any tension on that initial, don't put any tension on the suture, and it's harder to do than you think. But keep everything loose while you're going around your needle holders to make your second throw, because pulling on it lifts it off the tissues, and when you lock it, you'll have locked a loose suture. So again, a bit like the pulling through thing, people who are inexperienced find that they always lock it and find, oh, it's gone loose. And it's almost certainly because of this. So do your 2 throws, get it tight, keep it loose, do your final one and lock it. Once it's locked, you can crack on. But it's just that between those first and second throws that you need to be careful. And practice, practice, practice. Don't be shy. Get stuck in. The more you do, you'll feel awful at the start and it'll take you ages, but you get slick, don't worry. A real quick fly through of complications, because they hopefully don't happen very often. Bleeding, you'll hopefully have a heads up from your pre-op checks and your medical history, but repeat it when the patient comes in with bleeding problems just to check nothing's been missed, and take a specific bleeding history from that episode. They're terrible at estimating how much blood they've lost, but you know, was it cupfuls, was it sinkfuls? You might get, if they've got blood-soaked clothes and you're worried about them, take a blood pressure potentially if you've got that facility, just so that you can see that the patient's stable and you're not needing to treat this more seriously with, you know, an ambulance or anything like that. Triage the patient, and initially, if it's just a standard little bleed from a socket, put the pack in yourself and sit them in the waiting room biting for half an hour and then review. If it's still going, consider giving some local, or at least just suction, so that you can visualize what the source of the bleed is and also what the flow rate is. If it's minor, pack and suture well in the ways we've just described. Don't overpack it, as I've said already. And then review the patient after sort of 20 minutes, half an hour in your waiting room. If it persists, or when you look at it, it's a real heavy flow and you're worried, just pass it on. Just give Max Fax a ring, or your local oral surgery department. Adrenaline and tranexamic gauze, in my opinion, are of limited value. They can help. I'm sure most of you probably haven't got much of this knocking around in practice anyway. It can help if you're struggling. There's absolutely no harm in it, but it's not a miracle that you hope it might be. IV tranexamic acid is great, but again, you're not going to be doing that in practice. In terms of infection, you'll all be well used to dealing with it, but it's just a few little tips on it really. Think about the path of spread and where this has come from and where it might be going and into what space, because that, just for your own peace of mind, can give you a bit of reassurance, because one fat face is nowhere near as worrying as a different one if you know what you're looking for. And check the patient's not pyrexic and not getting quite unwell with this. Sepsis is a massive deal these days, so just really be careful that you're not missing something. An airway risk is obvious. How you manage it depends on the above. Make sure there's not an obvious cause if it's post-extraction, and that you've not left something in, or there's not a chunk of bone that's sequestrated that needs removing. Treat them with antibiotics, obviously, but if you can incise and drain something, then definitely do it. Learn to differentiate the difference though between a fat face because of edema and a fat face because of pus. Most of the time it's a combination of the two, and your job is to try and figure out how much of each is going on. Edema will be tender for the patient, but will be fairly soft to palpate. Thickened tissue certainly, but not that kind of hard collection of pus that's agonizing for the patient as soon as you press it. If you've got a ball like that, that especially in one of the sulci, that can be drained, then that's always better for the patient if you can. And obviously refer anything that you're not happy with or worried about. Dry socket, we all know about. Smokers, traumatic extractions, the pill, more common in the mandible, and mostly because of a loss of clot through something the patient has done, we like to think. But it also increased bone density. I don't know if I'm trying to make myself feel better with the last point, but I've certainly had patients where I've taken out single-rooted conical teeth that are just rotated out beautifully in the most atraumatic extraction you can imagine, and they just get no bleeding in the socket. and you're waiting for a blood clot and you're willing it to bleed, and it just stays pale and slightly pink bone with very little to fill the socket. And it's a worry from the start that that's not going to heal, because you need a clot to heal. And I have genuinely stuck a Mitchell's trimmer through the plates to try and encourage bleeding to fill those kind of sockets up. So it's just something to watch out for. Management, you all know, but irrigate with saline, not Chlorcidil. It's now written in guidelines, so if you go against it and anything bad happens, you're kind of knackered. There's no evidence that Chlorcidil is better anyway. And like I said, make sure there's nothing in there that's causing it. Tell the patient to stop smoking, because so many are caused by smoking, even if they tell you they didn't. In Europe, they tend to do local anesthetic and debride and really clean and curettage the socket and, inverted commas, make it bleed again to form a new cut, form a new clot. Nothing wrong with that, but if it can settle with Alagil, okay, then give it a go. If this persists and just doesn't feel right for you, then refer them, just to make sure that you're not missing out on something more serious with a non-healing socket. Tuberosity fractures, mainly isolated to upper eights, isn't it? Risk factors: a large chunky tuberosity or a large pneumatized sinus with quite thin walls in that area, so you'll get clues from your x-ray. An unfavourable root morphology of the 8, it can sometimes catch you out, and they can have roots like a jester's hat, which makes mobilising them way more difficult. Lone standing posterior molars, so it doesn't have to be an 8, but if you've got a 7 that's quite far back with no teeth either side, that's definitely a risk for, if you're not careful, for a tuberosity fracture, quite a big one. Age, as we discussed at the start, and less bone flexibility, sorry. And poor technique's not criticism, but it is true that poor technique and aggressive technique can sometimes make the tuberosity go. Signs are obvious. If it's ever happened to any of you, it's a horrible feeling. It's happened to me. Movement is what you'd say. More things move than you expect, or more things move than you want. Hopefully not the teeth next door, but that can happen. But often you'll see movement on the palate, and a palatal tear is almost pathognomic of a tuberosity fracture. So if you think you've done it and you look and you've got a bit of a tear in the palatal tissues, you've almost certainly got a tuberosity fracture. If you think you've got one and it's small and it's just a little bit of bone at the back of the wisdom tooth, I'd just carry on and take it out as long as you're able to, and it's okay. Check for an OAC afterwards and manage it accordingly, and possibly, if there's quite a bit of flapping gum in that area, stick a suture in for the patient just so it's opposed better and will heal. You can leave the tooth in place if you're worried about it, or if it's a bit of a bigger one. And either, if it's not in the way, give them soft diet, and if it's not in the way of occlusion, that might be enough. Or if it is, try and splint it in place, and you can get a suck down splint made if you want to. And definitely refer it, if you've done that. But the best thing is obviously to try and avoid it. So a little quick tip on trying to avoid tuberosity fractures. Most people will just stick a Coupland's in and try and elevate it with a Coupland's. The problem with the mechanism of action of a Coupland's is that it has to rotate through its circumference before it will bring the tooth downwards. So you always get that backwards motion before it comes down. And although it's not much, on some of the Coupland's 2s or 3s that you've got, that's quite a big distance. There's several millimeters of distal movement of that 8 that it needs to undergo. And if you've got quite unflexible or chunky tuberosity behind, that movement is enough sometimes to make the tuberosity go. And forceps clearly can cause a fracture as well if you're careless. But one potential way of avoiding it, and this is the way that I take my operates out, is by using criers. So you insert the tip of the criers through and get it as palatally as you possibly can. And then you start to rotate the tooth directly downwards. And then as you get it moving and as you create more space, you move the instrument more palatally so that that hook is wrapped right around and tucked into the mesiopalatal aspect of the crown. And then it can elevate downwards like that. And it works beautifully well most of the time, I have to say. And you get no or very little posterior movement of the tooth and hopefully save the tuberosity. If you struggle to get the criers in at the start, a little tip is either a luxator or a straight Warwick James just to open that space up so you can get your criers in. If you're unlucky enough to get an OAC, these are the kind of things to keep an eye out for. A pneumatized sinus, obviously, you'll see that on the x-ray. And lone standing molars that have lost their teeth either side because the sinus just drops down into where the teeth have gone. Definitely higher risk. Thin maxillary bone, traumatic extraction technique. Sherlock emailed me with regards to OAC specifically and saying, Is there an argument for taking cone beam scans to look at the risk associated before you take teeth out if they look high risk on a plain film? I personally don't think so, because I don't think it's going to change your practice in any way. I don't think it's going to change the way you take the tooth out. If an OAC is going to happen, it's going to happen whether you've done a scan or not. And your management of it post-optically is not going to change because you've had a scan. So I don't think personally, as long if you see there's a risk on the x-ray, just warn the patient on using the plain film, in my opinion. If you think you've got one, first of all, lie the patient back, good light, straight down the socket, and good aspiration to investigate properly. You'll see a very clear black hole if there is one. Most of them are small, really small, a couple of millimeters across. And if they are, they will often recover without any intervention at all. So you can just monitor the patient and give them advice, but do monitor them for closure. I've considered in the past putting a collagen sponge or a matrix into the space to try and establish a good clot over the top, with the thought that that will then grow over and close better. And I do think that's a sound technique. But the only thing you need to be really careful of is that you've secured well with a suture, whatever you're putting in that socket, because you don't want it getting dislodged into the sinus and potentially causing sinus infections or issues afterwards. Larger OACs, I would just refer. Even if you're experienced, I probably wouldn't attempt repair on the day, because I have to admit, I often don't, and our protocol in hospital is often, unless it really needs to, not to repair it on the day, because it's just much less favourable soft tissue conditions. Often we'll let it heal. It will either have shrunk or it might have closed completely, in which case it's great. Or if nothing else, at a later date, we've got better soft tissue to work with to get a proper closure. The antral regime you'll all know about. Don't blow the nose, don't hold their sneeze, let it fly. In terms of prescribing, I know a lot of people don't prescribe decongestants and just ask them to go and pick it up from a chemist because it's cheap and easy. And also with antibiotics, unless there's a load of gunk coming out of the sinus, if it looks clean, it's not absolutely necessary. You can monitor the patient and give them if there's any worries afterwards, but you don't have to give them every time. If you're worried about it, fine, but it's not essential. And absolutely no smoking. If it's a fistula that you've reviewed post-op, just refer it in, because it needs resecting out the whole fistula lining and then repairing formally, as we've discussed. I know a lot of people struggle with deciding whether or not a tooth's high risk for an OAC or not, so these are just a couple of cases that I've had in. And the tooth on the left, this upper six, I would say definitely is a high risk for an OAC. There is a really pneumatized sinus, and in this area here you almost lose that kind of lamina dura and cortex of bone, and you wonder whether there is any bone there or not. And it may not be the most straightforward extraction, which also makes it more likely to cause one potentially. The one on the right, I would say, is definitely less of a risk. There's a good border of bone, bridge of bone, certainly up here and around there. And while there might be a bit of pneumatization here, I think the bone that's around it there is going to make it way safer. And it looks like hopefully a more straightforward extraction. And in fact, the one on the left was an OAC. It's a tooth I took out, and it happened as I'd expected. This tooth, again, really pneumatized sinus, because we've lost the 5 and it's totally dipped down. And again, there's this mega thin cortex of bone with no convincing bone behind it or around it. And again, as you get apically, it's difficult to see what's around there, so I'd be worried about that one. Whereas this one I'd be a little bit less worried about. Agreed, at the apex, it's difficult to see quite what's going on, but certainly around here, I'm confident I can see bone right the way around that and right the way around that. I have to admit, I have to say so, most of the time, there's bone there, and particularly it might be thin and it might be a real thin plate, but there's often still bone around the tooth socket. It's quite uncommon that you don't have a bony wall around the socket, so if you can take the tooth out carefully and fairly atraumatically, you most of the time won't get one. But equally, if you're worried about it, it is totally a justified reason to refer it on to somebody like myself. Displacement of roots into sinus is a nightmare day at the office, but it happens, and really don't stress too much about it because it's very rare that it causes any major complications. Keep calm, reassure the patient and tell the patient and be honest about it, but don't look panicked, because if you're chilled out, they'll be pretty chilled out about it. Give them the antral regime, probably with antibiotics just in case, because you've put a foreign body into the sinus, and refer it. But again, it's not urgent. Feel free to give us a call on the day, but we probably won't arrange to see the patient on the day unless they've got any major problems. At the hospital, we'll either leave and monitor it, and particularly if we're not convinced it's in the sinus, if it's just slipped under the sinus lining. If it's under the sinus lining and looks accessible, we can sometimes get it through the socket, or sometimes we'll get it via a lateral approach. And I just chucked this case in out of interest. It was a route that had been displaced many, many years ago, as you can see by the fact that the gap where it was is now closed. So I think it was a 5, and the 4 and 6 have sort of drifted together, or I might be wrong. But anyway, it'd been up there for years, but the patient had recently started to get symptoms in that area. Dentist and us couldn't figure out where it was coming from. The teeth looked absolutely fine, and this was the only thing that was abnormal in the area. On the scan, there wasn't actually much to see in terms of pathology, so I wasn't convinced that it was the source of the problem, but the patient was just desperate to get it out and for us to rule it out as a possible cause, which is totally understandable. So using a cone beam CT scan, we can easily see where it is, and it's really close to the roots of that molar that's there. Take measurements, as you notice, on the scan, which is going to be my sort of landmarks when we then do the surgery. So raise a nice neat flap and get it up nice and cleanly. Use the measurements you've taken from your scan and your reference of the first molar to figure out where you're going to start making your cut. And I did this with the piezo for the specific reason that I was worried about damaging that 6, which we were so close to. We start to come across the root there, and you can just about see a little bit of sinus lining just above up here. So that's the sinus lining. This is the root that's lying in it, or just beneath it, sorry, not within it. And as you can see, I've actually come across the root of the 6 there, the mesiobuccal root of it, but because we're using piezo, there's absolutely no damage to that at all. So that's the whole point. It's nice and safe. So carefully flick that out and grab a hold of it without trying to push it in. And then once it's out of the way, we can have a good look and see that we've got a nice intact sinus lining there, which is the dream. That's exactly what we want to see. So it's as easy as putting everything back together and closing that up. So as I say, if you push a root into the sinus, don't panic. That is such minimally invasive surgery for the patient. It's not the end of the world. It can be worse, obviously, if it goes into the sinus proper, but that's quite rare. I was asked to talk about nerve damage. It's hopefully the rarest of complications for us all, but I'm going to talk about it only really in relation to taking teeth out. Clearly it's associated with wisdom teeth, and not many of you will be doing wisdom teeth, but I know some people do. But if you look at this diagram, this was a diagram talking about wisdom tooth extraction, but if you look at that lower second molar, the roots of that tooth also actually cross the nerve with a little bit of shadowing. And so do look out for it with mandibular molars. I'm not trying to make you all paranoid, but just keep an eye out for it because it can happen. It doesn't mean that you can't proceed and take the tooth out, but it does mean that you have to warn the patient of it, because the likelihood is you're not going to cause any trouble, but you do need to warn them. In terms of nerve damage, if you're unlucky enough to experience it, by all means give the Max Facts department a call to discuss it with somebody if you want to document it. But the University of Sheffield are a specialist unit in dealing with lingual and alveolar nerve damage, and they've got really, really good resources on their website for flow charts of how to manage it, how often you should review the patient, what kind of checks you should be doing on them, and at what stage you can refer to them, and you can refer to them if you need to. That QR code will take you to their page, but if you just Google, Sheffield Dental Hospital Nerve Department, it'll all come up, but they're good guys. Wisdom teeth and CBCT, I was asked to specifically just touch on and what my thoughts are on it. There are guidelines, European guidelines, which I'll talk about in a moment, and I know it's not relevant to most of you, so I'll keep it brief, but essentially I only scan wisdom teeth if it's proven high risk on a plain film x-ray, or looks it anyway. If I'm considering a coronectomy, because I will do a scan to prove it's high risk and to prove there's an association before I do a coronectomy, because if I do a scan and it's low risk, I'll just take the tooth out. If I do a coronectomy and haven't scanned it and it just looks high risk but might not be, you're leaving behind tooth tissue that may cause the patient problems, and you may not have ever had to do that. So in my opinion, the scan tells me to do the coronectomy, and rather than vice versa, because I know a lot of people will just do a coronectomy rather than scan. To me, it's kind of the other way around, and I think that makes more sense. If the only other reason I'll take it is if there's unclear or unusual root morphology, and I think it's going to change the way in which I take the tooth out. Because if a wisdom tooth is not suitable for coronectomy, grossly carious, unrestorable, and the roots look really nice and clear, there's a risk to the nerve, absolutely. The patient needs to be told about it, but there's still only one way to take that tooth out, and the scan is not going to make that better or worse for the patient, so there's no need to expose them, and that needs to be explained. The alternative reason, obviously, is if you're querying associated pathology like a cyst or something like that. And the guidelines kind of say exactly that they may give benefits if a close relationship's being found on plain films, but you can't routinely use it. And this is quite a cool video. I hope it plays over Zoom because it sometimes doesn't play videos that well. But it's just to give you an idea about perspective and why scans are really helpful. Because if you look at something from one direction, and in one way it can look like something, and from a different direction you get a totally different view of it, and it looks like a totally different beast. And that's kind of how I think it sometimes shows you up with wisdom teeth. So thanks for sticking with me, everyone. That is it.
Thank you, Robbie.
No worries. I'm sorry I went well over time, but it was a lot to pack in.
It's great.
So in terms of feedback and that kind of thing, that's a QR code for the survey, but I'm going to email it to everybody later, so don't panic about getting a hold of it. That's my email address if anyone wants to take it down, and please do email me with any questions, or even in the future if you just want to discuss cases or take advice or get some mentoring, anything like that, just give me a shout. But otherwise, has anyone got anything they want to ask now? There's loads of questions in the chat, so I'll start with those. All right. PRGF from Liam. I use it at the ICE hospital because we've got a machine, but we don't have a machine at Sandstone, but it's great stuff. And I was talking to a guy recently who thinks that the PRGF, for anyone who doesn't know, is platelet-rich fibrin or growth factor. Sometimes it's called PRF, PRP. But it's basically blood from the patient that's spun up to get rid of the bad stuff and keep the good stuff. And this guy reckons that he puts it in all of his private extractions, and he reckons it massively reduces dry socket. And there's also research looking into whether it works for reducing bisphosphonate necrosis. So it's something to keep an eye on for the future. Does anyone want to ask anything else? Can I end this so I can see people? Anyone want to unmute? No? Sorted? Everyone ready for a drink? Right then, well, I'll call it a day, guys. Thanks so much for taking the time to come and listen.
Thanks, Robbie.
Yeah,
No
cheers,
problem.
Robbie.
Hope it was helpful.
Thank you, Robbie.
Yeah, thank you.
Cheers, Robbie.
Same time next week. Cheers, Charlie.
Yeah, bye.
Well, bye.
See you guys. Thanks, Sam.
Thank you.
Cheers,
Bye.
Robbie. See you later.
Bye.
Bye.
Bye, guys.